Hello, my name is Sarah Ndagire. I'm a registered midwife. We are going to discuss about identifying and managing sepsis. This is the thing we always do at the ward, so it's kind of a reminder of what we have to do. We're going to look through what is neonatal sepsis, how common is it, classifying sepsis, how do we identify sepsis, and managing neonates with sepsis. I have a question, a simple task. Get a pen and a paper and you try to write down what do you understand by neonatal sepsis and why do you think it is important to understand it. Sepsis, this is a definition of sepsis, is an acute life-threatening condition characterized by organ dysfunction due to infection. And this is why it's important for you to understand it. It triggers systemic infections associated with hemodynamic changes or other clinical manifestations caused by bacterial, viral, and fungal. And it's also important because suspected sepsis is one of the most common diagnoses made in NICU. And then, how common is neonatal sepsis in Uganda? This is because, according in 2023, it was one of the third leading cause of neonates in Uganda. And also, approximately 11% of neonates in Uganda, it's also approximately 11% death in Uganda of neonates are due to neonatal sepsis. And also in Fort Portal Regional Referral where we work, between 150 and 200 babies are admitted in NICU are due to neonatal sepsis. 26% of neonates admitted in neonatal sepsis are due to suspected sepsis. Why is it important, or why is early identification critical? When you're able to identify sepsis early, it saves lives. And when you're able to identify early, it reduces on the complications and the severity of the infection. And this will also help us because we have a tendency of giving babies antibiotics before even knowing what you need to do. So it will also prevent on unnecessary treatments we give it to these neonates. And it will also help to reduce on detaining these mothers and their babies for so long in the hospital. I have another question for you. Get time to write down how is neonatal sepsis classified and why do you think it's important? Neonatal sepsis classification. We identify sepsis, neonatal sepsis. We have 3 classifications of neonatal sepsis. We have congenital, we have early onset, and we also have late onset.
Yes, I'm Edson Katsomyo. After looking at the classification of neonatal sepsis, where we have 3 types. We have the congenital, especially which is what we call the torches infections, which children or neonates acquire when they're still in the womb. The early onset and late onset. What is this early onset sepsis? With early onset sepsis, mainly that is the kind of sepsis that neonates acquire when they're what we call the vertical transmission, and mainly appears when it is up to 3 days. Beyond 3 days, we no longer call that one early onset. It moves to another classification. But in other countries, early onset can even be can even go beyond up to 7 days and even beyond. But with our country, Uganda, like in a study with Mugamba, which was done for her, she with colleagues, they classified early onset up to 7 days. But according to WHO, for it stands alone and says neonatal early onset should go up to 3 days only of life. When we look at the clinical criteria, which is mainly in the context within where laboratory findings normally comes late, and with early onset, 85% of these neonates mainly present within the first 24 hours of life, where we have a mid-peak of 6 hours. And 5% of these neonates mainly occur within 24 to 48 hours, which is 1 day to the second day. Late onset for it, it's that kind of sepsis where neonates will present with the sepsis signs from 3 days up to 59 days. But when we look at the definition of neonates, which can go up to only 28 days, so we say late onset can go from 3 days up to 28 days of life. So these are often associated with the healthcare environments where we have the nosocomial infections. Those are the hospital acquired. But now at times, if these neonates are born within the community, they can also acquire these infections within the community. So it is still within the environment of where the neonate is. And the infections, these nosocomial infections, are mainly on the skin, the respiratory tract, the conjunctiva, genitourinary tract, and some of them even appear on the umbilicus. But we have vectors which spreads these infections to these neonates, especially the catheters, the cannulas, the hospital equipment, the nasal prongs, the contact with the health workers, especially if they have got these infections, and even the attendants. Some attendants carry these pathogens that spread the infection. Why are these neonates vulnerable to these infections? First of all, we look at the immaturity of the immune system. Most of the time when they are born with immature, their immune system is still immature to defend themselves against these infections. So they end up with the infection. When we look at the skin, by the time they are born, most of the time, their skin is not fully developed. So it is still permeable to these infections, and they easily access the immunity, the specific saturation, and they end up causing some infections. Because it is documented that the skin gets fully developed after 10 days, even when the neonate has been born. So it is even worse to these neonates who are born prematurely. That is especially those ones who are born before 28 weeks of life in the womb. For them, they even lack the Vans caseosa, which is very important, especially in protecting these neonates. And it is documented that this caseosa mainly develops to these neonates in the third trimester. So prematurity alone predisposes these children, these neonates to, and puts them at risk. When we look at this diagram here, we are looking at how the immunity develops within the neonate, because now we're having these passively transferred maternal immunoglobulin G, which mainly develops before birth. This -6, it represents the 3 months. So it begins by 3 months. After 3 months, that's when it begins to rise, when the neonate is still in the womb. So close to 9 months, it reaches the peak and it begins dropping up to the 9th month after the baby has been born. But now at birth, there is this, the neonate also begins developing its own immunoglobulin G. So it begins now also to rise up to adulthood. But we are having also this IgM, which also keeps rising. So really at birth, you find that the immune system is not well developed for this neonate. So what are the main pathogens that are implicated to causing this neonatal sepsis? So the main pathogens which are implicated, we have the Staphylococcus aureus, coagulase negative Staphylococcus, and these two are mainly, actually, it has been found out that these two are the leading pathogens for late onset. Then we have this group B, Streptococcus, the E. coli. These two also are also the main pathogens which leads to early onset neonatal sepsis. We have Haemophilus influenza, Rickettsia monocytogenes, the Pseudomonas, and the Candida. All these pathogens have been found, actually, have been isolated to be causing neonatal sepsis. Why should we classify these bacteria as gram-negative or gram-positive? So the answer is just one. We want to classify these bacteria as gram-positive or gram-negative, so that they aid us to give the appropriate antibiotics, because they are antibiotics which targets the gram-positives, and other antibiotics target the gram-negative bacteria. So they aid in the selection. When we look at this neonatal sepsis, they are what we call the maternal and newborn risk factors. And among the maternal risk factors, we have the maternal urinary infections and abnormal vaginal discharge. We have the prolonged rupture of membranes for more than 18 hours. We have this offensive smelling and meconium stained liquor, then prolonged obstructed labor, then also this uncontrolled diabetes and HIV. Because now, like this HIV, if it is got when the baby is still in the womb, mainly because it is one of the torches, it also weakens the immunity of the father. So by the time the neonate is born, or is born with a weak immunity, and that one compromises its ability to fight the infections. Then we also have this, there are neonatal risk factors, like this low birth weight and prematurity, and we had seen prematurity that ideally, if because now with the prematurity, a baby does not have enough caseosa, it does not, the skin is not yet well developed, so which predisposes the neonate to the infection. What are the key symptoms of neonatal sepsis? Tell me the key symptoms of neonatal sepsis. Can you get a pen and write them down? Yes, there are many key signs of an unwell baby that may indicate sepsis. Among them, we have the abnormalities in temperature readings, especially where we have the high temperature above 37.5 degrees Celsius, what we call the hypothermia, or neonates who have temperature of less than 36.5 degrees centigrade, what we call the hypothermia. All these temperature irregularities points us for this neonate to be becoming a suspect, okay, of having neonatal sepsis. We have these cardiorespiratory distress situations where a neonate will present with high breathing rate, the fast breathing rate, especially if it is more than the normal ranges of the 40 to 60 minutes breath per minute. We have the bradycardia. When these neonates begins grunting, they have nasal flaring, they have the chest drawing, chest goes in and out, they have retractions. When they tend to develop cyanosis, where we have the blue coloration of both the mouth, the tongue, and the fingers, the fingernails, especially that one, what we call the central cyanosis. If a neonate presents with central cyanosis, that's a danger sign. That's an alarming sign that points this neonate to be unwell and is indicating sepsis. Also, when the babies have challenges, especially with feeding, when these babies cannot has gone ahead with refusing some feeding or breastfeeding, they cannot breastfeed, or some of them have developed some vomiting, irrespective of being supported, fully being supported on the breast or to breastfeed or to feed. Some of the neonates will develop some lethargy. They will become lethargic. They will become irritable. Where a neonate will be difficult. They will feel difficult to be waken up. Some of them will develop this jaundice, which is the yellowing of both the skin and the eyes. Even by the way, the urine can also turn to be yellow with this jaundice. So we are going to, some of them will present even with no urine or reduced output within the 24 hours of birth, because we expect them to begin urinating. Okay? But we have to be careful, because now this one may be indicating a pathological jaundice. So we have to assess properly. Some of the neonates will present with abnormal tone. Like some of them will have the hypotonia, others will be hypotonic, which is a sign of neurological disturbance. Some of them, of the neonates, will develop some rashes. But we have to be careful, because now these rashes we have to cross-check and assess them properly, because some of the rashes are unusual, or others are unusual to these neonates, are not common. So when we come across the neonates who develop some rashes, we have to carefully evaluate the rashes. Now, when it comes to treatment or managing these neonates with suspected sepsis on a postnatal ward, there are things that we normally give or we normally do. Mainly, it is supportive. We normally support. That's what we are supposed to do. And what are we supposed to provide in supporting these neonates? Especially, we're supposed to expose. Let us expose members. We need to expose these neonates, especially if they are hot, we need to expose them. If the temperatures are high, we need to expose. Why should we expose them? Because at times you find they are overcovered. So within 30 minutes of exposing them, if they remain hot, that is an indication that actually they're what? They have the sepsis. But there are others also. In our assessment, if we find that they have low oxygen saturations, when we take their SpO2 and it is less than 90%, we are supposed to provide oxygen. We administer oxygen. And we normally administer oxygen by nasal prongs. But now when we are giving this oxygen, we have to be careful. We have to keep reassessing the oxygen, because even oxygen itself is toxic, especially if it is given to up to 100 for some good time. So we are supposed to make sure that we maintain it below 100. We need to encourage this skin-to-skin temperature, especially what we call the kangaroo method. In case if the neonate has become hypothermic, the temperature has moved down below 36, we need to encourage the mother to put the baby or the neonate on his chest and cover. That is the kangaroo method. Now, in that process, if we realize that our interventions are not working very fast, or they're not yielding what we want to expect, what we're expecting from what we normally do, now we are supposed to inform NICHO to get ready to receive the neonate. Because now this was postnatal ward. Now we are shifting the neonate from the postnatal ward to be managed in neonatal care, intensive care unit. So we need to fill the forms and even inform NICHO. So documentation again comes in properly, so that we have to complete the documentation. And on our transporting these babies to NICHO, we have to keep a note that any delay that we may do or we may lead to will lead to will actually lead the neonate to deteriorate. So we need to work very fast and transfer the patient, the neonate, to NICHO timely. So whenever possible, a health worker should accompany in our transfer. We need to accompany these neonates to NICHO. But if in case, this is in case, and not, in case it is not possible, we have to use students if they are available. Or if the students are also not available in that kind of situation, we need to advise the attendants properly so that they can escort or take the baby to NICHO. And the NICHO should be informed that the baby or the neonate is coming to its side in the shortest time possible.
I'm Letty. We are on identification and management of neonatal sepsis. We have reached in NICHO. That baby was transported to NICHO. What are we supposed to do in NICHO? In NICHO, this baby is going to be received by the nurse. When the other transported nurse or the attendants, whatever, has brought the baby, quickly check this baby. Like in assessment, you are going to assess this baby to see whatever the baby has. You will continue to offer supportive treatment. If the baby needs oxygen, you are going to put that baby on oxygen. And quickly, you are going to take the vitals. You will take the temperature, pulse, respiration, if possible. And you are also going to inform the doctor about this baby who has come on the ward. While you are informing the doctor, you make sure that the file of this baby is ready. As this day's documentation is online, we are using computer. Open that file in the computer, enter the name or the particular of that baby. And if possible, if that baby's condition doesn't need oxygen, weigh the baby.
because this baby might need antibiotics. And we give antibiotics according to the kilogram body weight. And you are going to monitor this baby to interpret the vitals is more important. If you monitor the babies, take the vitals, make sure these vitals are okay. And you know how to interpret them properly. And the normal ranges. Do you know the normal ranges of the vitals you are taking? If you know how to interpret, you are taking it well. Do you know the normal ranges? For the heart rate, it ranges between 120 beats to 160 beats per minute. That one you have to know the baby is normal if the temperature, the vital signs are within that. Respiratory rate. A healthy respiratory rate of a neonate is between 40 to 60 breaths per minute. If it is lower or it is elevated, that is a sign of respiratory depression and might be a sign of infection. Temperature. Unstable temperature. A stable temperature should range from 36.5 to 37.5 degrees centigrade, and any ranges above or below 36, you have to make sure that you can continue taking the vitals again, because that one is abnormal. And only don't just take and leave it there, document and inform the responsible person, because that is an indicator. Oxygen saturation, ideal saturation level should be above 95% in a room air. For a preterm, this can be like 85% to 95%, which is normal. Our target is, then it should be from 90 to 93%. That one, it's a bit okay. But when it goes below that, that is already a red flag. So you have to be aware of that. What investigations are needed in the context of sepsis? What investigation do you think is needed for this baby who had sepsis? The investigations done when a baby has neonatal sepsis. As you see, the first one, blood culture, it is bold. We have put it in bold. What does it indicate? That is the gold standard for neonatal sepsis, because this is where we are going to get the right diagnosis. It is going to help us to get the right diagnosis, and it's also going to give us the right antibiotics to use for this baby, because we know the gram negative and the gram positive, which one is more sensitive. So it will guide us to give proper antibiotics and proper intervention. Blood glucose. We know a baby who had high or low is at risk of getting an infection. When this blood glucose level, you find the blood level is high, you know infections feed more on sugar. So there's risk of infection. Hemoglobin levels, why do we check for it? We talked of immunity. A baby with low immunity is at risk of getting infection. Lumbar puncture. Lumbar puncture, we do it mostly in case of baby with suspected meningitis. If a mother has some history of that, you do it. Though we don't do it on every child, but it guides us in the path of diagnosis. Urine microscopy or culture. Mostly we do this one in case of a baby who is having like high fever and other things. It helps us to rule out UTI in a baby. And C-reactive protein, it's being done, though rarely, but this one mostly is a measure to assess inflammation, which is also used in diagnosis of neonatal sepsis. Now, when we go do our investigations, these babies need antibiotics to be given. Which antibiotics are we looking at? There's first-line antibiotics, which is ampicillin, mostly 100 milligrams per kg, and it is given BD, that is 12 hourly, in a full-term baby. Gentamicin, you are going to give 5 milligrams per kg. And when the baby is a preterm, we use gentamicin 3 to 4 milligrams per kg. And this drug is given for 5 to 7 days. And this one is according to Uganda Clinical Guidelines of 2023. If streptococcal aureus is suspected, which presents with skin pustules, there's infection in the umbilicus, there's boils, there's septic arthritis, administration of cloxacillin or flucloxacillin. This one will help in bombarding those sepsis because it works faster than the ampicillin. But now if within the 2 to 3 days, this baby is not responding to these first-line antibiotics, what are we going to do? We have to shift. We are going to give cefotaxime, or we can start direct on meropenem according to the sensitivity. Monitoring response to treatment and look for complications. We are going to check the oxygen saturation, apnea, monitoring if possible. We are going to see the vital signs, treatment given, feeding, that is nutrition given, and the blood glucose. And when all these are done, what are we supposed to do? We have a monitoring chart. We are to document them down that these things were done. And if this baby improves on the antibiotics, and you have seen that this baby is improving by assessing the baby clinically and is responding on the antibiotics, the mother is happy of the baby is feeding well, actually then the vitals are normal, you can discharge this baby. When the mother is happy of the baby, is seeing the baby's breastfeeding, everything is fine on the baby, and the family members are comfortable that this baby can be carried home, the baby can be discharged. And you also advise on home care and when this baby can be returned back to hospital. There are some scenarios we are going to see, and we have to identify. We are going to use some scales for the scenarios. You either say the baby have some risk factors for sepsis, it's the clinical indicators for sepsis, whether there are warning signs, red flags, whether the baby requires antibiotics according to the scenarios. The first scenario is we are looking at Daisy, who is a term infant admitted due to suspected hypoxic ischemic encephalopathy, which is HIE, when the baby has some brain injury. There is evidence of seizures. The baby is having some fits on the CFM monitoring. Which scale are you going to give for this baby? Is this baby having risk factor? Is it having a clinical indicator for sepsis? Is it having a red flag? Or is this baby needs antibiotic? The second scenario is Aliyah, who is a 23 weeks infant newly admitted to neonatal unit following spontaneous preterm delivery. Her mother is on antibiotics for presumed sepsis. She is intubated and ventilated. So how are we going to scale this area? Is she a risk factor for sepsis? Mind you, she's also a what? A 23 weeks infant. She was spontaneously delivered and is a preterm. Her mother is on antibiotic because of presumed sepsis. And to make it worse, this baby was what? Intubated and ventilated. Is Aliyah a risk factor? Is having a risk factor? Is he having indicate for sepsis? Is he having the red flag? Does she need antibiotics? These are scenarios you have to know. When a baby comes with such, what are you going to do for this baby? Are you going to rush starting antibiotics? Or the baby needs it or not? The third is Azan, is a 36 weeks infant born by emergency cesarean section due to maternal PET, which is preeclampsia. The mother is having seizures already. Azan is clinically well at birth. So Azan, does he need antibiotic? Is he having red flag? Is there any clinical indicator for sepsis on this baby? Is there a risk factor for Azan? We still continue. We have a baby called Akiki. He's a term baby born through thick meconium. He is intubated and ventilated. Akiki is a term one and was born through thick meconium, was intubated and ventilated. How are we going to score this? A risk factor, you have a clinical indicator, red flag, or the baby requires antibiotic. We have also Susan, who is a 26 plus 3 weeks infant delivered by emergency cesarean section for maternal PET, preeclampsia still. She is intubated and ventilated. Most of these things, the scenarios are connected with the risk factor and the true. If we see the causes, they are all here. So if you go back and flash in the causes and the risk factor, you can answer these ones better. So George is an 32 weeks infant, now 35 plus 6, corrected. He was in a special care baby unit, but has been transferred back to intensive care unit because of apnea. Doctor thinks he has reflux. I think we know what is reflux. He was in special care, but now taken back to ICU. So this baby needs more care. Are we going to put on antibiotic? Is this just a clinical indicator? Has this shown the red flag? Last but not least is Winnie. Is a term baby on the postnatal ward. Her membranes ruptured 46 hours prior to her birth. The mother's membranes ruptured 46 hours prior to her birth. She is clinically well. Are you going to give this baby antibiotics? Is she having red flag? Is she having indicator for sepsis? Is she having risk factors for sepsis? So if we can answer this well, I think we can manage our babies accordingly, both on postnatal and neonatal unit accordingly. Well, thanks very much for listening.